ரூம்ல தானே இருக்கிறீங்க?
Sir, I was the clinic, sir.
கிளினிக்ல இருக்கீங்களா? ஓகே ஓகே.
Doctor, we are live now.
Tomorrow compulsory, I think.
Yes, sir. Yes, sir. I'll make my clinic in a compulsory, sir.
Doctor, we are live now, doctor.
Yeah.
Yeah.
Good evening, friends. On behalf of Tamil Nadu Ophthalmic Association, I extend a warm welcome to our guest speaker, Dr. John Gonzalez, who's Associate Professor of Ophthalmology at the Proctor Foundation, San Francisco. Of course, he is a very well-known person in the ocular inflammation, especially uveitis. And he is going to give you a talk on clinical approach and laboratory workup in the case of uveitis. Of course, he's done a lot of research work in cytomegalovirus, uveitis, zoster eye disease study, and keratoconjunctic and so many diseases. And of course, uveitis, all of you know very well, it's one of the very maybe you can diagnose easily, but to treat them effectively and correct to diagnose it correctly and also institute a correct treatment is very, very difficult. That I have seen in the last 35 years of my service is Ratnam, we can easily say, so this is a case of tuberculosis or sarcoidosis or something else. But for us as a general ophthalmologist or another field, it's a nightmare for all of us. So much of development in the field of uveitis that we are seeing even the clinical presentation, the diagnosis, and also the treatment. Previously, there was not much of treatment. Only you had to give steroids and with the cycloplegics. But now you are identifying the cause and treating the disease properly, and also you are going so much of other immunosuppressant, biostimulants, so many things, which is day by day you are doing something different. So in that way, this topic is a wonderful topic. And I once again welcome our guest speaker, Dr. John. And also at this juncture, I have to thank our Uveitis Chief of Aravind Hospital, Madurai, Dr. Ratnam, for organizing this guest lecture with Dr. John. And also Dr. Biswas couldn't join because of some personal commitment. And we have a wonderful panelist from Shankar Nethralaya, Dr. Sudha, and Dr. Venila from Trichy, Joseph. And of course, from Aravind, Dr. Vedanagi and Balamurugan, I think he has joined now. I think we have a wonderful, we are expecting a wonderful presentation and a panel discussion. And of course, Tamil Nadu Ophthalmic Association for John is one of the biggest organization in India. It's more than about close to 4,000 members, life members, ophthalmologist members. And we, for the past few years, we are conducting, because of Corona, we are conducting various webinars, symposiums, case presentation, journal clubs, and guest speaker like you. Every month we used to have this guest lecture by one of the international speaker, and it's an ongoing activity. So, and also we are having yearly conference like your academy, but it's this year also we are planning in Trichy, just near Madurai, about 200 miles from Madurai. So it's a very vibrant organization, and also you know very well that most of the teaching institutions like Aravind Hospital, Shankar Nethralaya, LVP, and other hospitals are all in South India. So ophthalmology is, of course, the knowledge is well percolated in Tamil Nadu. Definitely this symposium will be of very much, webinar will be of very much useful for all of us to give some idea about uveitis and laboratory work. After these few words, I welcome you once again. And before going to give the mic to Dr. Ratnam, I will request my TNOA Secretary, Dr. Sriram Gopal, to say a few words.
Thank you, sir. Gives me great pleasure to see the first person to teach me Uveitis, Ratnam Madam. Madam, I still remember so many of your teachings and our esteemed speaker. Welcome, sir.
I am very happy to see you.
Thank you, ma'am. Thank you so much. I'm sure uveitis is actually the lesser spoken of topics actually, but once you come back into clinical practice, you actually realize how important it is, and because probably you'll have to deal with every type of uveitis, and probably the crux of treating uveitis is investigating it. Investigating uveitis is the crux, because anybody can start a medication, but knowing what to investigate, when to investigate, and how far to go in a patient, in my opinion, being a VR surgeon, in my area, I double up as a uveitis specialist. Sorry, madam.
No. You are managing very well. I'm seeing your cases.
So I always have this, initially I always used to have this thing about how far to go, because you can always do everything under the sky for a patient, but you should know how far to go. I'm also very eager to listen about this, listen to this talk and learn more, because learning is a never-ending process. So I would also like to learn more. I'm sure I don't want to keep anybody waiting anymore. Welcome you, sir.
Thank you. Thank you, Sriram. I also welcome Madana Gopal, Ravi Kumar, Balamurugan, Prasanna. For the, yes, please go ahead.
All right, thanks very much, everyone. Thank you.
Dr. Ratnam?
Yeah. I really welcome John Gonasal, and he is one of our very good friends, as well as he is a very good speaker, and he is the apt person to talk about lab diagnosis, because he has the latest or more recent investigation, metagenomics, which is just upcoming. And we were supposed to have a project, international project with that. Unfortunately, we are waiting for still government approval. Metagenomic sequencing in uveitis will reveal so many things. And I'm sure Dr. Gonasal will be mentioning that also, even though it is very, very new. And he has published a lot, and he has received so many awards. And after Dr. Nisha, he is the one who has more collaborative work with Aravinda Hospital. Welcome, Gonasal. Please, we will start our session. We are waiting for your address.
Thank you so much, Dr. Ratnam, and thank you, Dr. Ramakrishnan, for the kind invitation. I'm really, really happy to be here with you all this evening. Thank you for staying up so late and using your Friday evening after, I'm sure, a busy day of clinics and such. So I'm happy to share with you. I'm going to share my screen here in just a moment, but happy to be here. I have fond memories of going to Madurai and Coimbatore. I haven't had the pleasure yet of going to Pondicherry, but I was telling Dr. Ratnam that I was last at Aravind in Madurai in, I think, 2020, like right before the pandemic hit. So I'd love to go back soon. And so we have some projects that we're all working on together. And so I think there's a lot of opportunity for me to go back to Southern India. I'm going to share my screen here in just a moment. Let me actually just, one second, I'm going to do it in just a particular way. Let's see here. Give me one moment. Here we are. And I'm going to, things are going to play here in just a moment here. Okay, so again, thank you everyone, and good evening. So I am excited to share with you a little bit about the lab workup in uveitis and kind of our current perspectives, our current methodologies, and our current testing assays, and then actually a glimpse into the future in terms of how I envision we might be managing some of the diagnostics with respect to uveitis in the future. So let me just mention that I have no disclosures. As uveitis specialists, we are tasked with determining whether or not a particular patient with ocular inflammation has infectious or non-infectious etiology. And so I think that's really, really important. Sometimes we get fooled because sometimes we end up getting fooled with a particular masquerade that mimics either a non-infectious or infectious process. But the reason it's so important, at least, to distinguish between an infectious or non-infectious etiology is that the treatment paradigms are entirely different. For an infectious process, we use antimicrobials. For a non-infectious process, we use immunosuppression. You could imagine that if we had an infectious process, but we were fooled into thinking it was non-infectious and using immunosuppression, that could be potentially devastating for the eye. We've actually seen this here, and I'm sure you all have had some experience where perhaps, for example, we've seen a case of acute retinal necrosis that initially was misinterpreted as being Behçet's. The patient actually received intraocular steroid injection, and then they were subsequently blinded because the viral infection was able to really propagate in this locally immunosuppressed eye. So at the crux of what we do, it's really trying to distinguish between infectious and non-infectious uveitis. And in the end, whether or not we can categorize something as multifocal choroiditis or PIC or serpiginous, that I usually say is sort of the cherry on top of a sundae, an ice cream sundae, because in the end, at least in the realm of uveitis, in general, there are not necessarily one specific treatment that is preferred over another specific treatment, at least in the way of immunosuppression. In infectious uveitis, it's a little bit different because the pathogen will dictate what type of antimicrobial we use. So in there, it's a little bit more important to actually more specifically categorize what type of infectious process we have. Now, before we start our exam, it's really important in uveitis to really talk with the patient in front of us before we start even looking at our patient. The reason that's important is that what the patient tells us with respect to their current symptoms, past symptoms, their past medical history, the medications they might be taking, all of that is really relevant in terms of what kind of diagnostic tests we'll be doing, including what additional examination maneuvers we might incorporate during the eye exam. So, for example, it's really important to ask your patient about not only the eye drops that they're using, but all of their medications, including systemic medicines. We know, for example, that immune checkpoint inhibitors are becoming increasingly used for a variety of cancers. That is associated with a variety of ocular manifestations with respect to inflammation. There are bisphosphonates using for prevention of bone resorption. So it's really important. Those are associated with ocular inflammation. So I always tell our ophthalmologists here to really be cognizant of every single medication that patients are using. Even Alphagan, we've seen Alphagan being associated with intense granulomatous inflammation and cicatrizing conjunctivitis. So you always ask and get a detailed history. Then it's also important, just also in the uveitis realm at least, to examine your patient. There are easily accessible body parts, the hands, the skin, the scalp, the oral mucosa, that might be important to examine, that might give additional clues as to perhaps a systemic etiology or systemic association with ocular inflammation. And then again, all of that put together then will help you identify the specific diagnostic tests or other investigations that one would like to order, because it's always a directed approach in terms of what we order, what tests we use for uveitis. Sometimes, often, younger ophthalmologists will order a whole battery of tests. You know, they say, I'm going to order the entire uveitis workup. There is no standard uveitis workup protocol. It's always kind of tailored to the patient in front of you. So sometimes a whole bunch of tests are ordered that really are not relevant to the patient's uveitis that's in front of you. It's also important to get a sense of the patient's inflammation, at least in terms of the descriptors of uveitis. This comes from the standardization of uveitis nomenclature. We like to ask our patient whether or not their inflammation or their symptoms of inflammation were rather sudden or insidious, because that can help us give clues as to the nature of their uveitis, whether or not the duration's been limited or persistent. So the duration, whether it's limited or persistent in terms of being less than or more than 3 months in duration, that talks about their current uveitis flare. So the patient who has active inflammation right now, the duration in terms of being less than or greater than 3 months in duration is talking about their active inflammation right now. The course talks about the lifespan of their uveitis. Over the entire patient's life, has their course been, for example, chronic, where they've had periods of inflammation greater than 3 months, or maybe it's been recurrent, where they've had periods of quiescence between their flare-ups of 3 months or more, for example. Those features, those descriptors can give us important clues about the possible etiology of their uveitis. For example, HLA-B27 related uveitis tends to be rather sudden, characterized by recurrences of inflammation separated by greater than 3 months of quiescence between flare-ups. Additionally, viral uveitis can also be sudden and be recurrent as well. So again, these descriptors help give us clues. And then in terms of anatomical location of inflammation, that's really, really important too. So finally, now we've moved to actually examining the patient in front of us and getting a sense of the features of inflammation in the anterior segment. So in this particular area, I'd like to look for corneal edema. I like to look for chorotic precipitates, the morphology or shape of the chorotic precipitates, their distribution. So this is relevant because stellate chorotic precipitates we tend to see more frequently associated with infectious uveitis, such as viral. Also, KP that extend above the corneal equator or are diffusely located or distributed also tend to be more associated with a viral cause of uveitis. And so if you see those features and perhaps maybe some corneal edema as well, that would suggest perhaps an endotheliitis. And if that's associated also with ocular hypertension during their flare-up, again, another convincing or suspicious sign for a viral etiology. And in some cases, for example, maybe you see a little bit of interstitial keratitis. That would prompt me maybe to check corneal sensation before we check intraocular pressure with anesthetic. Then it's important to look, for example, during your anterior segment exam for any iris nodules. We typically like to see our patients before they get dilated. It's a little bit different than in the retina clinic, perhaps, where everybody's dilated by the time the doctor sees them. But we do like to take a look at our patients before dilation. Number one, as the pupil dilates, sometimes that can release a lot of pigment, and it can be a little bit more challenging to assess anterior chamber cell. Additionally, when they're not dilated, we can look for iris nodules. We can inspect the angle, looking for nodules in the angle or bridging vessels, for example. Additionally, we can look for iris transillumination defects. Perhaps there's been features of iris involvement in the setting of a herpetic anterior uveitis. Additionally, perhaps there's been a little bit of subluxation of somebody's intraocular lens implant, and we can see iris chafing or something like that. So really important to look at the eye prior to dilation. And then moving into the vitreous cavity, features of intermediate uveitis, it's important to have our patients at the slit lamp once they're dilated to look down, up, and then straight ahead. That agitates the vitreous so that we can look at the anterior vitreous cell. Also, we can look at how the cells are arranged. Are they in sheets? That would be perhaps a little more suspicious for vitreoretinal lymphoma. Are there snowballs? That might be more suggestive of an intermediate uveitis or pars planitis. We also like to look at the morphology of the anterior vitreous cells. Are these single cells, or are they more clumpy, or are they more along the lines of perhaps fungus balls, for example, maybe suggesting either exogenous or endogenous endophthalmitis. Additionally, it's important to look at the periphery for intermediate uveitis, looking for any peripheral vascular sheathing or snowbanks. Looking at the posterior segment, we like to look for any active retinal or choroidal lesions. So we like to look for features of vascular sheathing. We like to look for retinal hemorrhages, retinitis, retinal whitening, or subretinal deposits. We do notice that it's important to do a fluorescein angiogram whenever there's a suspicion for either intermediate uveitis or any posterior segment inflammation. The reason I bring that up is because some of our patients we've recognized with either intermediate uveitis or posterior segment inflammation can have significant and diffuse vascular leakage on fluorescein angiography that we cannot detect clinically. So on clinical exam, their vessels actually look okay. We don't see any sheathing, but on On fluorescein, we can actually see diffuse vascular leakage, or we can see areas of occlusive vasculitis that are out of proportion to what we can see on clinical exam, for example, in Behçet's. So really important to do a fluorescein angiogram, at least at baseline in patients with either intermediate or posterior uveitis or pan-uveitis. And so I'm going to move now on to the diagnostic testing and the current tests that we kind of routinely employ or often employ in the uveitis clinic. And this is actually going to be a very visual representation of the lab or other diagnostic testing that we do. You know, the beauty of ophthalmology is that we can look directly into the eye. We can actually look with our own eyes and see the inflammation. And a lot of these tests that we do that often generate a report, you know, text report, actually are visual in nature. And so I think it's sort of nice to actually look at what these tests look like, or at least have a sense of, you know, what the test looks like that we're ordering. So it's really common. I would say that one of the tests that we always order in all of our patients with uveitis, there are few that we always order, but one of them is a chest x-ray, or alternatively a CT of the chest. And the reason that we're ordering a chest x-ray is that we're looking to see if we can find any areas that are compatible with tuberculosis. On the x-ray on the right, we see that there is bilateral hilar adenopathy. This is in somebody that had primary tuberculosis. Alternatively, we might be looking for similar features in somebody with pulmonary sarcoidosis. The chest x-ray on the left shows this dense homogeneous opacity in the right, middle, and lower lobes, which can be seen in pulmonary TB. Alternatively, you might see cavitary lesions, which might be seen in granulomatosis with polyangiitis. So the chest x-ray is really, really important in identifying patients that might have either tuberculosis or sarcoidosis. Alternatively, one thing that we will do here is if there's a high suspicion for potentially sarcoid being an etiology for our patient's uveitis, we will move straight to a CT chest as opposed to doing a chest x-ray first, because a CT chest, a high resolution CT chest, is much more sensitive for identifying features compatible with sarcoidosis. Now, not everybody that has pulmonary features compatible with tuberculosis necessarily have ocular TB, and I'll get to that a little bit later when we talk about some of the serologic testing for TB. But at any rate, chest x-ray is one of the most commonly, you know, used tests that we always order for all of our patients, and that's in contrast to the anti-nuclear antibody. So we rarely, if ever, order an ANA in our patients with uveitis. And the reason that is, at least in our clinical practice, and most practices, at least here in the US, is that very few of the patients with uveitis actually have lupus. And we'll look at some studies about that. But what does the ANA test look like? So what it looks like is here. It's a little dish full of these specific cells, HEP 2010 cells. And the ANA test is just evaluating the fluorescence patterns of formalin-fixed slides after the patient's serum, which presumably has the ANA antibodies, is mixed in with these cells. And then you get a variety of fluorescence patterns of these cells. So for example, you can see a homogeneous kind of staining pattern under the microscope, which we see frequently in systemic or diffuse lupus erythematosus, or alternatively rheumatoid arthritis. You can have a speckled pattern, which you can see in lupus, as well as other mixed connective tissue diseases and scleroderma. We can have more of a peripheral staining, where the staining is most intense along the peripheral around the circumferential area around the cell membrane, which we can see in crest as well as lupus, and then nucleolar staining rather, which we can see in conditions such as scleroderma. And here's a reason why we rarely check for ANA in our patients with uveitis. This was a study done a long time ago now by Dr. Rosenbaum, and looking at the pretest probability of having patients with lupus is rather low. And you can see here and highlighted in yellow that if a patient with uveitis was ANA positive, they have less than a 1% chance of having lupus. So that's to say, that's not to say that we never check an ANA in our adult patients with uveitis, but they really have to have compatible features of having a lupus-related vasculopathy or choroidopathy in the eye, or maybe they have on your clinical exam or review of systems some features compatible with systemic lupus. And so that this is in contrast though to children. So in children with, let's say, an anterior uveitis, their eye is wide and quiet, but they have a robust amount of inflammation in the anterior chamber. That's a little bit of a different story. ANA is relevant there because we're looking for patients that might have juvenile idiopathic arthritis associated uveitis. But in our adult patients, you can see here that we rarely are checking an ANA. And so here are some of the ocular manifestations that might prompt you to check an ANA. Again, these are mostly related to kind of vasculopathy features. There's some debate about how much of the vasculopathy that we see in the eye is related to frank inflammation or some other feature of lupus. But you can see cotton wool spots, for example, retinal vascular occlusive disease. You can have retinal vascular occlusive disease leading to retinal ischemia on the bottom left. And then we've also seen patients with an ischemic lupus choroidopathy. So in these kind of cases, you can see on the fluorescein on the right that there's this kind of square-shaped or triangular, rather, shaped zone of non-perfusion or lack of choroidal hyperfluorescence. So the choroid in that region is receiving little to no blood supply because of the lupus choroidopathy. Often you can see as a consequence or sequela, serous detachment in that region. For example, a lot of outer retinal edema. But again, you would look for these particular features, and that might prompt you to look for lupus. Moving on to another test that we employ, especially for patients who have, for example, scleritis or peripheral keratitis, is rheumatoid factor. So what does rheumatoid factor look like? So it's basically an antibody against the FC portion of an immunoglobulin. So we have an immunoglobulin here. We have a patient who's developed autoantibodies to the FC portion of IgG. And so this can be seen in 70 to 90% of patients with rheumatoid arthritis. So 70 to 90% of patients with RA are rheumatoid factor positive. We can see this in up to 100% of patients with hepatitis C virus, cryoglobulinemia, 70% of Sjogren's syndrome patient, up to 70% rather, with Sjogren's can have rheumatoid factor positivity. 10 to 30% of patients with lupus can have this antibody as well. And cryoglobulinemia is basically just this motif of immunoglobulin. So you have 5, kind of immunoglobulins that have been produced by the patient. So these are autoantibodies that, again, are targeting an FC portion of the patient's IgG. But it's important to remember, again, I talked about some of these conditions where rheumatoid factor is positive, but it's actually also found in normal and healthy population. Up to 10% of patients might be rheumatoid factor positive. So I don't check a rheumatoid factor for patients with uveitis, but I do if they have scleritis or peripheral keratitis. Then it's important to check for rheumatoid factor. Additionally, and you can see here that the sensitivity is not super high, 23% for rheumatoid factor, but it is very specific for patients with rheumatoid arthritis. We often combine the rheumatoid factor antibody test with anti-CCP or anti-cyclic citrullinated peptide. And what does that look like? So you can see that here, that anti-CCP antibody, which is here, is basically targets this post-translational modification to arginine. And so their sensitivity is about the same as rheumatoid factor, but the specificity goes up quite a bit, 98%. So testing for the combination of both anti-CCP and rheumatoid factor may be a lot better for excluding rheumatoid arthritis. And again, this is in the patient who might have features of scleritis. Again, I always tell our ophthalmologists it's important to do, if you can, an exam of their easily accessible body parts. And looking, for example, here we see a patient with swan necking deformity of their fingers and hands, which is compatible ultimately with rheumatoid arthritis. Along the spectrum of patients with peripheral keratitis or scleritis, something else that's important to check, again, in terms of directed labs, is looking for ANCA-associated vasculitis. So here we have a patient with this cavitary lesion right along the bridge of their nose. And so these ANCA-associated vasculitides are characterized by these autoantibodies that activate a variety of white blood cells, which then can lead to inflammation of the vessel wall. And so what is ANCA? So we have, I think that here I have these little kind of blinking antibodies that you can sort of see here. These are autoantibodies that are either targeting either PR3 or MPO. And so we have a different variety of ELISA techniques that we can use to demonstrate whether or not a patient is positive for these autoantibodies. And so you can see them here using fluorescence. We have either a peripheral ANCA pattern or a cytoplasmic ANCA pattern. So peripheral ANCA staining pattern typically correlates with anti-MPO antibodies, and that can be seen in conditions such as microscopic polyangiitis or eosinophilic granulomatosis with polyangiitis. Alternatively, the C-ANCA pattern correlates with typically anti-PR3 antibodies, and that typically correlates with granulomatosis with polyangiitis 90% of the time. It is important to be cognizant that there are some ANCA negative vasculitides. So there are occasions, for example, where if you have a patient like this, and even if they're ANCA negative, really a vasculitis is going to kind of produce this cavitary lesion. And even if they're ANCA negative, you might still call them having you might call them rather an ANCA negative vasculitis. But at any rate, patients with peripheral keratitis or scleritis, the labs that you're kind of mandated to check include rheumatoid factor, anti-CCP, and then ANCA-associated antibodies. Here, because syphilis is one of the great masqueraders or one of the great imitators, we always check all of our patients, whether they're a child or an adult, for syphilis. And so one of the non-specific tests that we always check is the RPR, rapid plasmin reagent. So what is the RPR? So we can see here these spirochetes attacking a variety of the host cells. And what happens here is that the host cell, when it's damaged, ends up releasing cardiolipin and lecithin, which is in the cell membrane. Our body then develops antibodies against the cardiolipin and lecithin. These are known as anti-lipoidal antibodies. And so we can do tests to look for these anti-lipoidal antibodies. And basically this involves mixing the patient's serum plus a cardiolipin antigen solution and then charcoal. And so what happens basically is this. So we can see that the patient has these antibodies to the cardiolipin antigens. We're mixing the patient's serum, which contains the antibodies. And what ends up happening on the bottom there is that we form this nice lattice network. And so when you form this nice lattice network, charcoal is trapped within the lattice and it ends up coming out of solution. So this is a very visual test. I mean, this is, a human is looking at this test to see if this charcoal is coming out of solution and if they're RPR positive. That's basically what's happening here. So you can see here we've got strongly reactive test, weakly reactive, or non-reactive. It's entirely based on visual inspection. So, RPR is not specific for syphilis. 1% of adults without syphilis will have anti-lipoidal antibodies. And again, why might somebody be RPR positive? We just saw that sometimes when there's cell wall damage, our bodies might develop antibodies against that cardiolipin and lecithin that's released. RPR is found also in other infectious conditions like mononucleosis, viral hepatitis. Patients that are IV drug users might be RPR positive. Lupus, leprosy, pregnancy, and all old age are also associated with being RPR positive. So things to keep in mind, especially if your clinical exam, the history is not matching with this patient having syphilis. RPR is helpful because the titer does correlate with disease activity. When you do have syphilis, it becomes positive during primary and secondary infection, and the titer correlates with response to treatment. So you're expecting to see a drop in RPR after appropriate treatment. It's important to know, though, that the titer can drop if syphilis becomes latent. We always also pair the non-specific testing with a specific treponemal test. So for example, the fluorescent treponemal antibody, which is a solid phase assay. And so you can see here, we've got the patient's pink antibody that is targeting treponema. And then it's a fluorescent test. So if the patient's antibodies are binding to the treponemal antigen, then we'll use a fluorescent antibody reporter. And you can see it's also a visual test. So ophthalmology is visual. A lot of these tests are visual in nature. And so you're just looking to see if you can see ultimately the spirochetes, that are positive or that are lighting up because the patient has antibodies against the treponema. It's important to know you can have false positives in specific treponemal testing. So leptospirosis, we can see that, lupus, primary biliary cirrhosis, rheumatoid arthritis, leprosy, and malaria. So again, this is where a thorough review of systems might help you identify false positive treponemal specific antibody test. And this is just kind of going over some of the different methodologies that can be done. Moving over to tuberculosis, this is another test. So we talked about chest x-ray. Everybody with uveitis or scleritis gets tested. We also talked about how patients with, everybody with uveitis or scleritis always gets tested for syphilis. The other thing that everybody always gets tested for is tuberculosis. And so historically, we used to do a lot of PPD placements, and it's important to know what's contained in PPD. So it's 92% protein, or 93% protein rather, about 6% polysaccharide, and then 1.2% nucleic acids. So the sensitivity for identifying TB, depending on the area of induration that develops, is 75%, and the specificity is 85% for identifying TB. So it's good, but not the most perfect assay. And part of the reason is that there are some problems with the assay. For example, HIV sarcoidosis or immunosuppression may result in anergy, and so the patient may not actually develop an appropriate immune response against the PPD antigen. Additionally, it can be positive. You can have a false positive when somebody has an infection with a non-tuberculous mycobacterium, or prior vaccination with Mycobacterium bovis, for example, the BCG vaccine. If somebody's been vaccinated before, they will appear positive. And so that's certainly the case in TB endemic areas. Because we're often getting a lot of blood testing anyways for our patients, we've moved on to just checking a serum interferon gamma release assay. So what does that look like? What does an interferon gamma release assay look like? So the important components of it, of assessing interferon gamma release, include the patient's antigen presenting cell, antigen specific T cells, and then also the appropriate antigen. So for TB, the appropriate antigens that we're really looking for are ESAT6, CFP10, and TB7.7. So what happens in the interferon gamma release, what happens in general when our bodies have encountered TB antigen, is that our antigen processing cells are going to process the antigen. They are going to present those antigens now to antigen-specific T cells, and then that T cell produces interferon gamma, and that's what we're measuring in the interferon gamma release assay. And so here's what the test looks like. One of the nice things about interferon gamma release assay is it doesn't cross-react with BCG, because we're using TB-specific antigens, and it can identify false positive TB skin tests. So it's performed in this order. The first tube, which is called nil, means that there's no stimulation of T cells. So we're just looking at the baseline interferon gamma release, because of course all cells release a baseline amount of interferon gamma on some level. So we're looking for baseline interferon gamma value. Then we actually expose patient's blood to TB antigen, which again, remember, are those 3 antigens. And now we measure the interferon gamma level compared to that nil tube. And then finally, we do a phytohemagglutinin or a P assay, which is it's non-specifically stimulating the T cells, because we do want to make sure that their T cells don't have some aberrant response to kind of anything. And so that's kind of a sensitivity check, or what do we call it? A sanity check, rather, just to make sure that we're performing the test appropriately and that there's no aberrant response in the patient's blood. And the results are positive, negative, or indeterminate. If you get an indeterminate value, that doesn't mean that the patient doesn't have TB. It just means that there was perhaps some kind of error in the processing or sequence of the testing. And so you should consider repeating the test 3 to 4 weeks later. So there's another paper by Dr. Rosenbaum and his group in looking at the post-test probability, rather, of having a patient with being PPD positive specifically and having uveitis. What's the likelihood that they're going to have TB as an etiology of their uveitis, and you can see it's actually a pretty low percent chance of them having TB uveitis. So again, this was a long time ago. It was there in 1990 that this paper came out. This paper was produced in Oregon, which is the Pacific Northwest of the United States, and U.S. in general is not a TB endemic area. But then, since the 1990s, the U.S. and especially the West Coast has become increasingly cosmopolitan. We have a lot of patients or people that live here now that are from TB endemic areas. We have people in healthcare that might have been exposed to TB. So now I don't think that this kind of rationale in terms of you really shouldn't check for TB really applies. It is true that not everybody that tests positive for TB exposure necessarily has TB as a cause of their uveitis, but where it's relevant to know if they have TB or not, or latent TB, is if we're going to be starting them on immunosuppression because we feel that all of their features are compatible with a non-infectious uveitis. We do want to know if they have TB because their TB could become reactivated depending on the immunosuppression that we use. So it's really important to identify whether or not people have latent TB, regardless of whether or not we ultimately in the end think that their etiology of uveitis is related to TB. Moving on to HLA typing. So HLA typing is particularly relevant in some specific uveitic and ocular inflammatory conditions. But what is HLA exactly? So HLA is part of the MHC class 1 molecules, which are present on all nucleated cells as well as platelets, but they're not present on red blood cells. So you can see here that the MHC class 1 molecule, which is in green here, is made up of alpha chains. There's 3 alpha chains. They're polymorphic from each other. There's also another constituent of the MHC, which is beta-2 microglobulin, which we'll talk about in a little bit. But basically, the MHC class 1 or HLA is presenting antigen or to cytotoxic T cells. So that's what the HLA test looks like. There's different types of HLA. And these are the associations of HLA in uveitis. HLA-A29 in particular is associated with up to 100% of patients with birdshot chorioretinopathy. So usually, if we have somebody with ocular manifestations compatible with birdshot, but they're not HLA-A29, we typically think that it's related to some other process and probably not birdshot. HLA-B27, there's a high association with the seronegative spondyloarthropathies, in particular ankylosing spondylitis. We see it in a high proportion of reactive arthritis. So in patients with a recurrent acute anterior uveitis characterized by an intense amount of inflammation, hypopyon, that's something that we might be thinking of in particular as an HLA-B27 related seronegative spondyloarthropathy. Another HLA subtype that often comes up is HLA-B51, since there's an association with Behçet's disease. And while some studies, especially from Mediterranean regions, find that the prevalence of HLA-B51 in Behçet's disease is 57%, there's also a high prevalence of HLA-B51 in healthy controls. And it's important to remember that HLA-B51 is not part of the diagnostic criteria for Behçet's. We never recommend ordering it because it's ultimately not going to change what we do for the management of the patients. So HLA-A29 and HLA-B27 definitely are something that should be ordered in the appropriate setting, but really HLA-B51, I feel, has no role in terms of identifying if somebody has Behçet's or not. It's really an entirely clinical diagnosis. We're coming back to we're coming back to the beta-2 microglobulin molecule that's on MHC because this comes up for tubulointerstitial nephritis and uveitis. In that condition, we're assaying urine beta-2 microglobulin. And so beta-2 microglobulin has been used in some cases as a biomarker. For example, it can reflect activation of cellular immune response systems. It's a tumor marker, at least in some malignancies. Beta-2 microglobulin levels rise during infection with some viruses, and an abnormal urine beta-2 microglobulin indicates renal filtration or resorption disorders. So as an example, what happens in the renal tubules is typically urine beta-2 microglobulin is resorbed back into our bloodstream, And in inflammatory disease, such as tubular interstitial nephritis and uveitis, when there's inflammation, then that resorption is not possible. And so urine beta 2 microglobulin then is excreted into the urine, and we're measuring that. And during inflammation of the kidneys, there's increased amounts of creatinine that are resorbed into the blood. And so when we're checking a urine beta 2 microglobulin, it's important to also check serum creatinine. So from this study from Hedinga, when beta 2 microglobulin is greater than 1 milligram per mil in a patient with compatible uveitis, the positive predictive value of them having TNOA as an etiology of their uveitis is 88%. When you combine that with an elevated creatinine, the positive predictive value goes up to 100%. So, often these patients may not need a renal biopsy to demonstrate tubular interstitial nephritis. I think that the serologic testing for the creatinine, measurement of the urine beta 2 microglobulin would suffice often for our nephrologists. And in those kind of settings, when they have a compatible uveitis, they can move straight to first-line management with systemic corticosteroids. And it's important to remember that TNOA does not only present with anterior chamber inflammation in a child that maybe had strep throat or is complaining of dark colored urine. We have seen instances of TNOA in adults even that's been characterized by inflammation in the posterior segment. We have this patient pseudocolor fundus photo on the right with all of these kind of choroidal orange spots. They also had areas of vascular sheathing, and we can see here some vascular sheathing with some leakage on fluorescein angiography. So we will often check a patient for TNOA if they have either an undifferentiated anterior chamber inflammation, or alternatively, they have posterior segment inflammation. So, coming back to we just spent some time talking about some of the most kind of classical tests that we use in uveitis and part of our diagnostic workup. And I think that covers a fair amount of the tests that we order. I mean, it doesn't sound like much, right? There are not that many. And a lot of those tests are used in a directed approach, in particular, if a patient has scleritis or peripheral keratitis, or if a patient has ocular inflammation. There are some tests we always order: chest x-ray, syphilis, and TB. But let's come back to this issue of infectious versus non-infectious uveitis. And again, the reason it's important to identify specific types of pathogens is because we have to use specific types of treatment. Now, one of the issues at the Proctor Foundation, we have a long history of using cultures for identifying infectious pathogens associated with ocular infections. So routine bacterial and fungal cultures have been the historic gold standards. For example, SCUT and MUT used bacterial cultures and fungal cultures. But the issue with routine cultures is that many pathogens are difficult or unable to be cultivated with the routine culture process. So with the introduction of these pathogen-directed nucleic acid amplification tests, they have a superior sensitivity compared to cultures, and they're now kind of considered the standard of care for diagnosing infections. But one thing to keep in mind is that no infectious PCR assay is FDA approved for ocular specimens, but we still are routinely using them. Now, another problem with diagnosing ocular infections centers on the eye itself. The eye is so small that it's only able to offer very minimal amounts of fluid with which to do testing. Additionally, even though we have a lot of tests related to nucleic acid amplification tests, there's still relatively few that we have. We have directed PCR for HSV, VZV, CMV, and toxo, but that's really it. So in greater than 50% of presumed infectious cases of uveitis, we fail to identify a pathogen because we are limited by the small volume of fluid we get from the eye. Routine cultures are not perfect, and we have a limited amount of molecular tests that are routinely available to us. So my colleague and friend Thuy Dewan really revolutionized how we identify infectious processes as a cause of uveitis, and this is using metagenomic sequencing. So the beauty of metagenomic deep sequencing is that we can sequence any genome or any nucleic acid that's in a particular specimen. It is able to sequence that particular genome without having to do a directed approach. So it's agnostic testing or it's hypothesis-free testing, meaning usually when you are looking for an infection, you have to order the appropriate assay. You have to order HSV and VZV. If you did not order a toxo PCR, then you're not going to be able to identify that particular segment for toxo. But in RNA or DNA sequencing, it's able to sequence any genomic material that's present in the sample. It sequences it, and then the bioinformatics pipeline comes into play because all the genomic material that's sequenced is then compared to known reference databases and then tells you what is present in that particular sample. So it's important to remember that sequencing is half the battle. The other half is that you have to have a good bioinformatics team to help you identify what genomic material you've identified. And also you need to have stringent criteria because sequencing picks up any contaminant, you have to be able to distinguish what's a contaminant, what's more likely to be a true infection. The other important thing is that we're also sequencing the human genomic material because, of course, there's a host inflammatory response typically in the sample that you're taking. And typically we've removed the host genomic information because we're only interested historically in looking for pathogens. So let's take a look at this in play. We'll first start outside of the eye. We had a particular study that actually happened in southern India where we looked at the utility of using metagenomic sequencing in some cases of conjunctivitis. There were 14 samples, and in 10 of these samples, we identified adenovirus. 2 samples, actually, we were not able to identify any pathogen. But interestingly, in 2 of the cases of conjunctivitis that appeared to be adenoviral in nature were actually related to Vitiforma corneae, which is a microsporidia. And this was in 2 patients, both of whom were immunocompetent. So that was really, really fascinating. And again, we don't have a routine PCR to look for Vitiforma corneae. It's really hard to culture that. So it was, this shows us the utility of metagenomic deep sequencing on the ocular surface. So now let's go into the eye. We had a case of a patient with a heterochromic iridocyclitis kind of picture. They had iris atrophy. You can see that there is transillumination defects. On the photograph on the bottom right, you can see that there were stellate keratic precipitates that were diffusely located. They had ocular hypertension during their flare-ups of uveitis. It had all the classic features of a viral uveitis, but this patient had numerous anterior chamber paracenteses from both eyes, always negative on directed PCR for HSV, VZV, and CMV. And so ultimately, the patient was sent to Proctor because the suspicion was, since the patient's negative on directed PCR, it's probably a non-infectious etiology. Please start the patient on systemic immunosuppression. But when we saw the patient, we felt so strongly that this had to be an infectious process, most likely viral. But even under our hands, the patient routinely tested negative for HSV, VZV, CMV. The patient even developed a vitritis at one point. Vitrectomy was done, still negative for HSV, VZV, and CMV. And so ultimately, when TWE came onto our scene, we actually had some specimens that had been banked, and this was, a case that had stumped us for a long time. And so she applied metagenomic deep sequencing from an anterior chamber fluid sample that had been left over, and she was able to identify this 9600 nucleotide sequence that was mapped to rubella. And the fascinating thing is that using RNA sequencing, we're able to identify the entire genome of the pathogen. So we can actually identify what kind of strain it is. And this patient sample was most compatible with a strain that's been identified in Stuttgart, Germany, which is where our patient had originally come from. So it was really, really fascinating. This was one of the first forays that we had into using metagenomic deep sequencing to identify an ocular infectious cause of uveitis. Here's another case that sort of had us stumped for a little while, a patient that had required that actually developed cataracts at a rather young age. I suspect that he had uveitis or a low-grade inflammation for a while that led to the development of cataracts at a young age. But at any rate, when he came to us, he was bilaterally pseudophakic. He had ocular hypertension. And so he had tubes that were placed, but he still had ocular hypertension, had developed this anterior chamber and anterior vitreous cell, was sent to us for further management before he had his next set of tubes placed into his eyes. And when I saw him, he had an anterior intermediate uveitis, and the workup was negative, including syphilis, TB. There was nothing in the posterior segment at that time. And so I started him on steroids, and the patient actually got worse. This patient did have a history of having some headaches and memory loss, and he did have a known prolactinoma that neurology knew about, but they were unconcerned about. And when he started the oral steroids, he actually got so much worse. He ended up developing macular edema and these pre-retinal precipitates. At this juncture, I was concerned about either a neoplastic process or some kind of infectious process. And we did a vitrectomy, which was negative for lymphoproliferative process. It was negative on cytopathology as well as flow cytometry. And then cultures were negative, but we had previously done an anterior chamber paracentesis before he went for the vitrectomy. And when we sequenced the anterior chamber fluid, we found the genome of Tropharima wapellii. And so what we ended up doing was having the pathologist go back and do acid fast staining, and they were able to find this PAS staining rather, and they found this PAS positive material in these macrophages. So this, entirely changed the treatment course for this patient. By the time that we found out these results, this patient developed significant mental issues with respect to having oculomasticatory myarrhythmia, having much more problems concentrating. I think he would have died had we not identified Whipple's. The interesting thing is that historically he had no weight loss, no skin rashes, no problems with bowel movements. Again, just this, like when we asked the wife about any problems, she said, oh, he's having some headaches. But again, that was correlated perhaps with his known prolactinoma. So really, I think that metagenomic deep sequencing saved this patient's life. Now let's turn, so we can see how metagenomic deep sequencing can help us, especially when it's an unusual pathogen or a pathogen that's hard to culture or cultivate. But let's turn to non-infectious uveitis. For example, I had mentioned that when we do sequencing, when there's ocular inflammation, we actually get information about the host genome. And in the past, we were interested in only identifying pathogens or microbes. So we would always remove the human genetic information. But we are now able to actually go back and look at that human genetic information and see if there is an upregulation of certain genes, or if there are other factors that might be associated with a non-infectious autoinflammatory disease state. So, for example, we were interested in looking at sarcoidosis. Ocular sarcoidosis, especially when there's no pulmonary disease, is very hard to diagnose. And so what we ended up doing more recently, I'm going to skip through a few slides just in the interest of time, was to recruit 10 patients that had uveitis compatible with sarcoid. 8 had pulmonary disease, 1 had CNS involvement, the other had a conjunctival involvement. We also recruited patients with void Koyanagi Harada. And the reason we recruited these patients is that VKH and sarcoid are both granulomatous diseases, but they're both clinically distinct in terms of the manifestations that they feature. So rarely do we confuse the type on clinical exam. We also recruited 9 healthy controls. And what we did is we just looked at their peripheral blood and we wanted to see if we could find, using our RNA sequencing, peripheral blood transcriptome. And so what we did is that we ended up finding that there were 10 genes that exhibited a 4-fold difference in the expression in sarcoidosis patients versus our controls. And all of these genes are involved in really important kind of canonical inflammatory pathways. And so here we can see on this heat map the expression of these genes and how these expression patterns really distinguish between sarcoidosis and VKH as well as controls. If we look at this volcano plot, as it's called, which plots out the relative abundance distributions of the transcripts, we can see that the genes in blue here that are above this line are statistically significantly expressed to a higher degree compared to the other types of genes. And then if we do something where we actually use a Venn diagram to look at how the peripheral blood transcript profiles relate to those found in other disease states. So we're making comparison between the genes expressed between control and sarcoid, the different genes expressed between control and VKH, and then VKH and sarcoid. We see that actually there's no overlap between these expression patterns, which is really, really interesting. So I'm going to come back to that because we were just talking about peripheral blood transcriptome. We're able to look at that. Let's come back to that case where we looked at those patients with conjunctivitis and we identified a pathogen. We wanted to see if we could also look, because with each swab, we're also collecting epithelial cells from the conjunctiva. Maybe we can also try to identify or distinguish these two different disease states based on the host response, the genes that are being transcribed as a consequence of being exposed to a virus or to microsporidia. And you can see actually that they separate really, really nicely in terms of the inflammatory genes that are upregulated. So it separates nicely where we're able to distinguish between a viral infection, the genes that are transcribed, versus microsporidia. So this might be another possible avenue to make diagnoses. Maybe we don't always necessarily need to diagnose the specific pathogen. We may be able to distinguish between viral or non-viral based on the genes that are being transcribed. And then more recently, we are also interested in looking at the host genome information by looking for malignancies. So one of the problems with vitreoretinal lymphomas is that while we have a variety of tests, whether it's cytopathology, whether it's directed PCR looking for IgH, gene rearrangements, flow cytometry, interleukin 10 to interleukin 6 ratio, and now more recently, directed PCR looking for mutation in codon 265 of the MYD88 gene. Despite all these tests that we have, we still often fail to identify lymphoma or diagnose it. So we have a high clinical suspicion when we have the right patient, but we still are often thwarted by having negative tests. And so here's a patient, for example. This is a 56-year-old woman who had vitritis only, no retinal lesions, just a vitritis, not responding to oral steroids now. So we had a suspicion that she had lymphoma. We did an anterior chamber paracentesis just to make sure it wasn't an infectious cause of uveitis, negative on directed PCR for viral pathogens, no pathogens on deep sequencing. This patient ended up having vitrectomy since we were suspicious for a lymphomatous process. And then we got the pathology report. On clinical exam, we saw a lot of vitreous cells, but we did not see, but the pathology report said that it was modestly cellular, that there was a polymorphic population of lymphocytes, but it was essentially negative for lymphoma. And so what we ended up doing was I got the slides myself to look, and I saw that the specimen had a lot of lymphocytes. So remember, hematopathologists are typically the ones looking at these slides. So for a blood sample or compared to a blood sample, yes, this is modestly cellular, but for a vitreous sample, this is wildly cellular. And I saw myself many atypical lymphocytes that were suspicious. So I sent these slides on to an ocular pathologist in Texas. She identified 3 atypical lymphocytes. I also sent to her the cell block, and using IgH gene rearrangement assay, she found this being positive for a diffuse large B-cell lymphoma. So I went back to Dr. Dewan and I said, can we look at the host genome that we acquired from the anterior chamber paracentesis? Can we identify any lymphoma-associated mutations? In fact, this patient had 6 lymphoma-associated mutations, one that conferred mitomycin resistance, mitomycin C resistance. So mitomycin C is not a typical chemotherapeutic used for vitreoretinal lymphoma, but it's really impressive that we can identify mutations associated with chemotherapy resistance, because I think that in the future, this might play a role in terms of how we might use or tailor therapy in the future. So in conclusion, it's really important to do a thorough review of systems, get a thorough medical and social history, and also review of medication. That's really, really vital in terms of helping you identify what possible etiologies might be at play for your patient's uveitis, as well as what possible tests you should order. Clinical features of uveitis in terms of the duration or the course of uveitis in terms of using the uveitis descriptors is really, really important. Looking at the anatomical location of uveitis is very important. And then also looking at the nature of the inflammatory cells on the cornea, iris transillumination defects. Those are all really, really important in terms of helping guide the relevant testing that needs to be done. Keep in mind that the tests that we always order in almost everybody are chest x-ray, syphilis, and tuberculosis. It's really important for us to distinguish between non-infectious from infectious uveitis because the treatment paradigms are different. Problems identifying infections are a small sample size that we get from the eye, and then some pathogens are really hard to cultivate. There are problems with identifying lymphoma, small sample size again. Often we get few cells or they degenerate, which often make it hard for them to be processed by the tests that we have right now. So metagenomic deep sequencing is exciting because it's an unbiased technique and it concurrently sequences both pathogen genomes as well as host genomes. We get a lot of information from that. It requires very little fluid, as little as 20 microliters of fluid, and may provide better biomarkers than what we currently have, and may allow for more precise and tailored therapy. So with that, I'd like to thank everybody for your kind attention. I have a great team that I work with, Nisha Charya, who I think everybody here knows and is quite famous in the world of uveitis, Dr. Dewan, that heads our metagenomics deep sequencing labs, and then Jessica Shanta. We work as a team. We have a real passion for uveitis. And again, I thank you all for listening this afternoon, or this evening, rather. I'll stop sharing now.
Yeah, such a wonderful talk, John. It was wonderful and very clear. And all recent investigation, you made it so clear. Everybody, I am sure that everybody understood. And you didn't mention leptospirosis case in metagenome, which you published.
I know. So I didn't mention the leptospirosis case, but that was another case that stumped us. So we had this fascinating patient who, so, you know, we never see leptospirosis here in San Francisco, but we had this patient who had multiple sclerosis. He was failing therapy. He wanted a stem cell transplant. His MS doctors said, we do not recommend a stem cell transplant. So he went to Mexico to get the stem cell transplant. He was going to pay out of pocket for this procedure. Shortly after arriving in Mexico, he got sick, nausea, diarrhea. He ultimately recovered and then went on to have a stem cell transplant. And after the stem cell transplant was completed, he started to have blurry vision. He was given steroids without even an eye exam in Mexico, and his uveitis, or his inflammation, his blurry vision got worse. Finally comes back to the States. He had numerous anterior chamber and vitreous taps for cultures, for 16S and 18S RNA, all negative. And so he came to us, and we were still suspicious, just like all the other doctors, that he had an infection in the eye. So, you know, I think our clinical, I think clinically we know when something in our heart is either infectious or not infectious. But the thing that always makes it challenging is when all of the infectious tests, even if done a number of times, is negative. Like, what do you do then? And that's where metagenomic deep sequencing can help us. So metagenomic deep sequencing, I don't think should be used in every single case. I think HSV, VZV, CMV, PCRs are very sensitive. They're you know, toxo, those work well, but these are for these really challenging cases, especially in infection. I think deep sequencing can be helpful.
Any questions from the audience?
Can I have one more?
Yeah.
Yes.
Please.
Thank you for an amazing talk, sir.
Yes,
Sharmila, sir. Sharmila, ma'am. Thank you for an amazing talk, sir. I just have one query. Will anti-CCP become?
Oh, I think Sharmila's.
RA factor become?
Your voice is breaking. We are not hearing you.
Could you
I
repeat
just want
it?
to know, ma'am, whether an anti-CCP will become positive even before an RA factor becomes positive, because many patients, when we do an RA factor, it is negative. But then is it very significant to do an anti-CCP before, because that might turn out positive earlier than an RA factor?
That's a good question. I'm not sure if anti-CCP becomes positive before rheumatoid factor. We always order the two together. So rarely do we order a rheumatoid factor alone. And if it's negative, we'll go back and check a CCP. Usually we order the two together. Now, if we're seeing a patient with scleritis and we notice that in the workup, only a rheumatoid factor has been done, we'll order an anti-CCP. And I can't tell you what the prevalence of rheumatoid factor negative but anti-CCP positivity is, but I suspect, because there is a higher specificity for rheumatoid arthritis in general. So remember, anti-CCP isn't any more sensitive than rheumatoid factor, but it is more specific for rheumatoid arthritis. So remember, you can have RF positivity in a number of cases, but I think anti-CCP being negative is really helpful in ruling out rheumatoid arthritis if it's negative.
Thank you.
Panelists, do you have any questions or comments?
I'm looking in the chat, and let's see here.
Everybody appreciates you.
That's nice. Yeah, there's some talk. There was a discussion about beta-2 microglobulin, and the creatinine avoids biopsy diagnosis of TNOA, which is exactly right. Dr. Balamurgan mentioned that. So correct. Hi, Dr. Balamurgan. Nice to see you.
Really enjoyed your talk.
My pleasure.
Really appreciate your splendid efforts in making this presentation a grand success. I have a doubt, in the newer emerging infectious diseases like West Nile, Ebola, do you apply the metagenomics, and have you succeeded in identifying some of them?
So we are collecting samples from all over the world to identify these really rare cases. I'm not aware yet that we've identified West Nile virus yet. And typically what we do is we do serologic testing when we have a compatible case of West Nile. So I'm not aware of us having identified West Nile yet. Excuse me. And then for Ebola, we have, as far as I'm aware, we have not. Dr. Shanta, our newest team member on the uveitis team, she actually is an Ebola uveitis researcher. So she's been to Sierra Leone and those places and been very, very involved. I'm not aware if we have any samples, but again, if there is any genomic material from any pathogen in a sample, RNA sequencing or DNA sequencing will be able to identify it. So it's a very powerful technique. It's able to identify anything. So we've had some cases of that looked very much like an exogenous endophthalmitis after cataract surgery, and we've been in at least a couple of these cases identified C. acnes. Initially, when we saw these cases, I thought, oh, we have an answer, C. acnes. C. acnes is so ubiquitous and it's such a common contaminant that Dr. Dewan reminded me that she is, suspicious that it's a contaminant and it's actually not the cause of these patients' uveitis, although it looks so much like an infection, and we ended up removing the IOL in those cases. So, the other thing about deep sequencing is because it's so sensitive, you get so much information, including information about contaminants. You really have to correlate your results with the clinical exam. There's no test yet that still says, without any doubt, this is the answer. So there still is no perfect test.
Thank you. Thank you for a clear answer. I have another doubt. If you permit, I can ask you that. And when you test for syphilis, you have two algorithms. First, a non-treponemal followed by a treponemal test, or vice versa. How do you follow in US?
We always do the two together. So we actually order both at the same time. And the reason we do that is because we have had cases where somebody was RPR non-reactive, but on a subsequent test, they in fact were FTABS positive. So we know that there are certain situations like pregnancy or HIV where actually the patient may be treponema antibody positive, but RPR non-reactive. If you recall, when I was showing that picture of the RPR where you have to form this lattice structure and the charcoal is trapped in between, in a condition like HIV, actually, there can be an exuberant production of antibodies, RPR antibodies. And what happens if there's too many antibodies, then you're not going to form a lattice structure. You're not going to trap the charcoal. So the test will look negative when in fact, if you dilute the patient's serum, then it will be positive. So that's known as the prozone effect. I've seen 2 cases of this prozone effect here in San Francisco. So it's always important to do the 2 tests together because there are situations where the RPR can be non-reactive, but in fact, the patient still has syphilis, and you would not know unless you did a treponema specific test. So our hospital actually has an algorithm where you check RPR first, and if it's positive, then they would reflex to test FTABS. But we always order the 2 separate, even though the hospital doesn't like it. We always order the 2 together because I've seen a case of syphilis where somebody had only RPR testing. They had an injection of steroid and they lost the eye because in fact they were FTABS positive. So after these things happen, we just force everybody to get both a treponema specific and a non-specific test together.
Wonderful. Thank you. Thank you for a clear answer.
Sure.
Any other
Dr.
panelists?
Dr. John, I have one question.
Yes.
You mentioned about the anti-glaucoma, the alpha agonist, belimumab may cause granulomatous uveitis. Of course, we have seen few cases of granulomatous uveitis. What's the real mechanism of that, and is there any other drug that can cause such a problem uveitis?
I think Alphagan, there are some few case reports. I've been meaning to write up our case report because his inflammation was so intense and associated with this horrendous cicatrizing conjunctivitis. I'm not exactly sure what the mechanism is that leads to such intense anterior chamber inflammation. I mean, clearly we know that the drug penetrates into the trabecular meshwork, so there must be some host response against the medication, presumably, that leads to this inflammatory response. This is in contrast to, medicines that are associated with like direct toxic effects, like I'm trying to think of the medication that's used intravenously for cytomegalovirus. The name escapes me right now, that we use in some cases. Cidofovir. Thank you, cidofovir. So cidofovir can cause the uveitis as well, but that's actually related to a direct toxic effect of the medicine in the ciliary body and the iris. But that's not what's happening. My impression is in Alphagan. I think it's perhaps the reaction against the medication. This actually happened, the most severe case I saw was in somebody that had been using Alphagan without any real obvious issues for at least a couple of years. So it wasn't even a new exposure, but it was a cicatrizing conjunctivitis that ultimately, to me, implicated the Alphagan. I don't think if he had the cicatrizing conjunctivitis, I would have necessarily thought of the Alphagan. But once I saw the cicatrizing conjunctivitis, we stopped the Alphagan, and finally he became control. His uveitis, went away. But that was a tough case. Sadly in uveitis, it takes us a while. Sadly in uveitis, as you all are aware, many times it's not the first or second or third visit where we have a good sense of what the etiology is.
I agree.
Thank you, John. Dr. Velanagi, Vanilla. Velanagi, any questions?
Good evening, sir. No, sir, one small question. Do you have any specific algorithm, like in your clinic, when you have a patient with an anterior uveitis intermediate. If you see in our country setup, we have a specific algorithm which is more towards an infective etiology. You showed us the list of investigations, but
Yeah.
I know everybody tailors it down according to the presentation. But do
Yeah.
you have a specific algorithm or a baseline investigation which you do before you go on for further investigations? Like, I think it will
If
be
it's-
useful for people outside as beginners,
Sure.
like to know what will be your line of investigations.
Yeah, I mean, definitely, patients with anterior chamber inflammation, it's really looking at whether or not there's corneal edema, the morphology of the keratotic precipitates, the distribution of the keratotic precipitates, any transillumination defects or associated ocular hypertension. Those features, to me, are most compatible or suspicious for a viral etiology. And so in those cases, we'll do an anterior chamber paracentesis instead for directed PCR for virus. We also do a lot of confocal microscopy. And so we will look at the morphology of the KP there as well, looking for dendritiform KPs. I also look at the morphology of the endothelial cells to see if there are any areas of endothelial denudation, spot-like holes, things like that we've identified in herpetic infections, keratitis, as well as anterior chamber inflammation. If the inflammation is more, keratotic precipitates that are primarily inferiorly AC cell, I'm more likely to think it's if it's bilateral, I'm more likely to think it's non-infectious. And then if we're talking about anterior and intermediate uveitis, again, it comes down to the morphology of the cells in the vitreous space. So if they are in sheets in particular, if they're not sort of evenly distributed through the vitreous, but instead they form these sheets, you have the patient look up and down and you see these sheets of cells, I'm more suspicious of lymphomatous process. And so then we'll end up having them, pretty quickly go to a vitrectomy for cytopathology and flow cytometry. If instead, they've had a history of surgery and we see these fluffy anterior vitreous cells, I'm going to think more of a exogenous endophthalmitis that was introduced during their surgery. And then, and that also sort of the age range, if it's a young person with vitritis and we, fluorescein angiography demonstrates peripheral vascular leakage and we've ruled out in syphilis and TB, then I'm going to think it's more of, undifferentiated or idiopathic non-infectious uveitis. So, those clinical features I think are really, really key. Keep in mind, once we've ruled out infection, the big one we really have to rule out is an infection, because once you've ruled out that, then it really just is managing the inflammation, the non-infectious uveitis. The only type of uveitis where there's a preferred line of management would be for Behçet's disease in particular, because especially Behçet's vasculitis, because in that kind of setting, there's a consensus or agreement that if possible to start that patient on an anti-TNF agent. But otherwise, there's no, as far, we don't have, there's some randomized trials right now trying to distinguish between anti-metabolites or T-cell inhibitors versus first-line anti-TNF therapy, but we don't have that data yet. But right now there isn't one medicine as far as we know of that's better than another for immunosuppression in non-infectious uveitis. So once you've ruled out infection, categorization of the specific type of inflammation outside of Behçet's vasculitis is not so dire. It's just managing the inflammation.
Yes, sir. Thank you. So it's more of a tailored down, like looking at the whole picture, we tailor down the investigations. Thank you.
Sure, of course. Yeah. I know it's late for you all there. I think it's 10.
9:20.
9. That's
9:45.
okay.
Ma'am, and even the ocular tuberculosis workup, I think for us is slightly different from what Sir mentioned, ma'am. Can you
I'm sure it is.
Elaborate a little on it, ma'am, Professor Ratna, ma'am?
In fact, we give more importance to Mantoux than quantiferon. That is what our personal experience when we compare Mantoux helps us a lot. At least to tell whether even in pediatrics, if it is positive, it really helps us. Because BCG is given on day 1 of birth of the child when immune system is not even matured. So BCG induced positivity is very rare. In children, if it is positive, we have to be very careful And even though it is a child, if possible, imaging is CT imaging is better, and we rule out with the help of CT as well as full body examination for any lymphadenopathy. And some of the adolescents now, they have come with the mesenteric lymphadenitis and abdominal tuberculosis and tuberculosis anywhere else, any extra pulmonary tuberculosis other than pulmonary tuberculosis. So our workup is a little more extensive, and we have cerebral tuberculosis, and we have genitourinary tuberculosis. So all those things we have to consider, and we have to work with the physician in close association. Invariably, physician will say that there is no problem, but as John mentioned, as a view of a uveitis person, even as very, very small clue towards tuberculosis, we have to take it very serious.
Thank
And that is very important.
Yeah, I mean, you all are seeing so many more cases of TB than we see. So that, I mean, our approach is quite different, I think, just because we see so few cases in general, comparatively speaking.
Okay. Any other questions? No other questions. Then I will request our Joint Secretary, Dr. Sharmila, to propose vote of thanks. Sharmila.
Yes, sir. Good evening, everyone. On behalf of President Ramakrishnan, sir, and the office bearers of Tamil Nadu Ophthalmic Association, it's my pleasure to propose the vote of thanks for this wonderful meeting on workup of uveitis. We are really privileged to have this meeting with an international UV expert and the who's who of in UVA in India, Professor Ratna ma'am and Professor Biswas sir, the chairpersons, but unfortunately, Professor Biswas sir couldn't join today. Thanks to President Ramakrishnan sir and Chairman, ARC Chairman Dr. Atik and Professor Ratna ma'am for organizing this webinar, which was not only an eye-opener for UVA specialists, but also for cornea specialists like me and the general ophthalmologist. And my sincere and heartfelt thanks to the guest speaker, Dr. John from University of California, San Francisco, for sparing his time and for enlightening us with his enriching experiences. And, that topic covered so many new topics, which we are looking at it for the first time. And I especially like the slide on ANA, the different types of patterns, the speckled and all those patterns. I've never seen that slide anywhere. So many slides were very interesting and nice, and a lot of inputs were given. And thanks for sharing your experience, sir. It was definitely a big eye opener for all of us. Thanks to Professor Ratna ma'am and the panelists, Dr. Balamurugan sir, Dr. Vanila, and Dr. Vedanayaki for their expert inputs and guidance. And thanks to all the attendees for patiently staying for a very long time. We have a good audience, YouTube audience. And thanks to the tech support, Numerotech, and Mr. Sai and Mrs. Manjula for coordinating this well. Thank you, everyone.
Thank you. Thank you, Elegant, for sponsoring this.
Thanks to Elegant.
Thank you, Elegant.
Thank you, John.
Thank you
Thank
all.
you. It was a wonderful topic.
Thank you.
It was a pleasure to
so
be
much.
here. Thank you
Really
all.
appreciate it.
Thank
My
you.
pleasure.
Thank you, sir.
Make
So
it
much of
great.
learning. Yeah. Good night.
Thank you
Good
so
night.
much.
Thank you.
Good day.
Bye.
Thank you for getting up very early for us. Thank you.
My pleasure. My pleasure.